Welcome everyone. Let's go ahead and begin our webinar. Welcome to the webinar today facilitated by the National Alzheimer's and Dementia Resource Center, formerly the ADSSP National Resource Center, which consists of our team at RTI International. I'm Siri Schumann with the Resource Center team, and I will be moderating our webinar this afternoon. The purpose of these webinars is to provide helpful, current, and applicable information for ADSSP and ADI grant projects and others in the Aging Network. Please note the webinar today is being recorded and the PowerPoint presentations will be sent after the webinar. Today we will hear from Jed Levine and Ann Wolf about their experiences reaching people with dementia in difficult to reach areas. First we'll hear from Jed Levine, who is the Executive Vice President and Director of Programs at the Alzheimer's Association New York City chapter. He has been on staff there since 1990. Jed has taught at Columbia Mailman School of Public Health and Hunter College School of the Health Professions. He is a member of the New York State Coordinating Council for Services Related to Alzheimer's and Other Dementias, and is a member of Senator Gillibrand's Working Group on Aging. He is also the principal investigator for the chapter's project, Palliative Care for Advanced Dementia, Training and Implementation. A frequent guest on radio and TV, Mr. Levine has presented nationally and internationally on dementia care, family caregiving, and disaster preparedness for persons with dementia. Jed, I'll turn it over to you for your presentation.
Okay, thank you very much, Sari, and good afternoon, everyone. I'm delighted to be here to talk to you about our experience reaching out to the LGBT community. Just a little bit of background first, and I know many of you are very familiar with Alzheimer's, just to make sure that we're on the same page. In the way that we view Alzheimer's is that this is the major public health crisis of the 21st century. There is, the numbers support that, and as you know, every 67 seconds another American develops Alzheimer's disease. There are over 5 million Americans who have the disease, and it's the 6th leading cause of death in the United States. Though according to a recent study in neurology last summer, put that figure as the 3rd leading cause of death. So it's also important to note that it's not just a disease of aging, although it is predominantly a disease of aging, but that about 4% of people with Alzheimer's are under the age of 60 or 65. And so, and that presents a whole other set of issues for the families that are dealing with, for the individual and for the families. And, I'm proud to be associated with the Alzheimer's Association, which I have for the past 25 years. And we are the leading organization for care support, awareness, research, and advocacy around Alzheimer's and other dementias. And it's important to recognize that it's not just Alzheimer's, because I've had families say to me, gee, I didn't realize that my dad had vascular dementia. I didn't realize that, we could have gotten help there. So it's important that folks know that we deal with all cognitively impairing illnesses. Another important element to note is that all of our services are free of charge for people with the disease and their families. And there's a whole host of services which I won't go into, but the majority of families who reach us connect through the 24-hour helpline. And when families are dealing with Alzheimer's disease, whether they are traditional families or gay and lesbian families, I think people often feel so helpless. There's this sense that there's nothing you can do, and people kind of throw up their hands and think there's nothing you can do. Well, we know, and I know that I'm kind of preaching to the choir here, that indeed there's so much that can be done in terms of improving the quality of life for the person with the disease, and also supporting family members, providing them with guidance and information and education and support. But when we talk about reaching out to the gay and lesbian population and the bisexual and transgender population, and that's what LGBT stands for, it's important to recognize that some members of those communities don't feel comfortable reaching out to an organization unless they feel that they are going to be welcomed. and we'll talk a little bit in a moment about the issues of being inclusive and how to provide a welcoming and affirming environment for them. So at the Alzheimer's Association, both here at the New York City chapter and nationally, we have now, it has been a core value and principle for the association now, and it's part of our goal is to make sure that everybody who needs this information and support can get it within the context of their culture and within their community. And this has been an effort that we've been involved in New York City for many, many years. Given the diversity of the city and the multiple communities here, and I'm proud to say that we've been working formally with the LGBT community since 1995, so that's 20 years of history. So we seek to be inclusive of the millions of people currently affected by Alzheimer's disease, their caregivers, and the communities in which they live. A little bit of background, and I think it's important to recognize, because often people say, well, are there really special considerations for older gay men and lesbians? And I'm going to focus on that particular part of the LGBT community because that's where I have most experience. But certainly we are inclusive of bisexual and transgender folks as well. But I think it's important to recognize that these individuals who grew up in the 1930s, the 40s, 50s, and indeed in the 60s, and even in the early 70s, that at that time it was very rare for an individual to be completely out and to be open about their sexual orientation and their attraction to the same sex. People lived hiding a very important and essential part of themselves. And that hiding takes a lot of energy and creates that sense of living with a secret. And indeed, there was good reason to hide it because at the time, those behaviors, homosexual behavior, was criminalized. You could lose your job. You could lose your apartment. You could be thrown out of your church or your house of worship. There was a real fear of what could happen as a result of being open about your sexuality. And certainly that came very often from the family of origin. So it's not uncommon now in large urban areas that were more welcoming to gay men and lesbians that they lost contact with their family of origin and no longer have those supports. And now that they are older and need that kind of support, they have to find that someplace else. So this is very much, a very important factor in terms of the life experience of older gay men and lesbians. And I think if you're interested in learning more about it, there's a wonderful documentary that was done in 2010 called Gen Silent, or Generation Silent, but it's Gen Silent. And I would encourage you to look that up and see if it's being shown anywhere in your area. And you can also you can work with the producers to arrange for a screening in your area for professionals or for the community. I think it's a really good learning tool to understand how these individuals were affected by this historical fear and discomfort in sharing who they were. And the things are changing with the Stonewall generation, and Stonewall happened in the late 60s, I believe in 1969, when there was an uprising in a gay bar in Greenwich Village here in New York City. And there was a sense that was the beginning of the gay liberation movement. And several years after that, about 4 years after that, the American Psychological Association, or Psychiatric Association, had a landmark decision that depathologized, that removed homosexuality as an illness. Formerly it was seen as a mental illness. So no wonder nobody wanted to be identified as being gay or lesbian. So that was also a very important landmark decision. And then fast forward another 10 or 12 years, we unfortunately had the HIV and AIDS era and crisis here, which really both completely devastated the community in many ways, but also, I believe, has been a source of great strength in terms of the resilience and the community involvement and how folks came together to advocate and to provide care for each other. So I think when we're talking about older gay men and lesbians, it's important to have a sense of the historical perspective here. So also to recognize that in the past 20 years or so, there have been some major public policy victories and some major milestones that have moved to a much more accepting societal environment. I will say that there are certainly there are some situations where it's still, or some areas where it's still very uncomfortable and very and potentially dangerous to be open about your sexuality. But we're seeing much greater acceptance in the larger population and in especially among younger adults. So. In 1992, President Clinton's administration passed the Don't Ask, Don't Tell that allowed servicemen and women to serve as long as they did not openly declare their sexuality. And in 2004, so 11 years ago, Massachusetts was the first state to legalize, quote, gay marriage or same-sex marriage. And that has led off to a very rapid societal change where now 38 states and the including the District of Columbia now have legalized gay marriage. And so there are statutes pending in other states, and there's a movement, and as you know, the Supreme Court is going to be taking up this issue. So this is really an issue that is transforming the landscape, and transforming the landscape for older gay men and lesbians, many of whom have been partnered for decades, who never considered the opportunity for marriage. So it's an important consideration here. And of course, Don't Ask, Don't Tell was abolished several years ago in 2011, and in 2013, the Defense of Marriage Act was repealed, so that the federal government said, and government employees, that same-sex marriage would be federally recognized. So it's important to take a look at that. So why were we looking at developing specifically support groups for gay men and lesbians? And there was a time when we were doing this back in 1995. My original supposition was that it was going to be for men and women who were caring for their partners, and that didn't turn out to be true. Yes, that was a part of the population we were providing services for, but it was often people who were caring for an aunt, a cousin, a parent, and so it wasn't what I had originally thought. The other element to think about here, or consideration, is that degree of comfort. We were hearing from some of our support group members who were gay or lesbian that they were perfectly comfortable in a spouse's support group. But depending upon who the group leader was and who the members of the group were, there was some discomfort, or there was some sense that they were not being treated, or their relationships were not valued in the same way. So that was one of the motivating factors for us to develop services for the LGBT community. The other piece to think of here is that because the people who are now providing care for a relative with dementia probably lived through the HIV and AIDS era, that trauma gets reawakened again from the AIDS epidemic. Often their first caregiving experience was for friends or partners with AIDS. And there is this own reflection or self-awareness of their own fear of getting seriously ill or dying, and reawakening those feelings as well. So how did we do the recruitment for LGBT group members? First of all, let me say that it was important that we partner with the major provider for uh, social services and supports and community for the LGBT elders, and that is Sage New York. And so we worked with them from the very beginning, and it's been a very successful partnership. And we worked with their clinical director, and we've done a lot of cross-referring and a lot of work that's been very productive. So that was the main source of our referrals. But we also did some education and training for our 24-hour helpline and our care consultants who are social workers who provide one-on-one guidance for families through our family caregiver workshops where LGBT members are identified. They're told about the group specifically for LGBT members, through our education meetings, referrals from diagnostic centers so that they know that when they're dealing with LGBT people that they can refer them to us. And then we also put out calendar listings in LGBT populations. So the marketing campaign is actually not dissimilar to what we do for our general support groups as well, our mainstream support groups. Special considerations for the LGBT population is that it's not unusual for a person to be caring for more than one person. And I remember visiting a support group that we do with Sage and hearing a woman whose name I believe was Roberta said that her mother and her partner were actually in the same nursing home, and so she could visit both at the same time. There was a need to talk about intimacy and something that's very personal without the fear of being judged, and that sense that I spoke about earlier about feeling misunderstood in groups for straight spouses, where their relationship was not as valued. As somebody would say, well, it's not the same, your caring for your partner is not the same as my caring for my wife or my husband. So people obviously did not feel comfortable in such a group. And because of the historic fear of being rejected, not being accepted, so being uncomfortable in coming out, in disclosing their sexuality in a straight or a mixed group. So some of that historical knowledge, I think, is still very relevant. Other considerations that they understand each other in a way that people who did not grow up in a gay environment or lesbian environment in the 40s, 50s, or 60s don't speak the same language, so they have that existing bond already, and they needed a group, and this is something they told me, to share their caregiving concerns without the exhausting burden of hiding their sexual orientation. They could simply be who they were and be accepted for who they are. So, all right. Other things that have come up as members' concerns for the group members is about a fear about who is going to care for them. Many LGBT seniors never had children, or their partner has died, so they are concerned about that. Often there is an assumption from other family members that the gay adult child will do the caregiving because, quote, they don't have children, so they don't have a family to care for. They're a little bit freer to do that. And a major concern is that in different provider settings, in home care, adult daycare, or nursing homes, that they will encounter homophobia, or that, and I've heard this frequently, that the home care provider, who might come from a different culture and might not be as accepting, that's a bit of a generalization, might try to change the individual. The other, one other piece to recognize is that not uncommon to see friends caring for friends and a whole network of friends caring for each other. So that's important as well. I think there are many concerns that are actually universal, whether one is in an LGBT group or in another group for spouses or adult children, so I'm not going to go into those at the moment. I do want to talk about some of the resources that are available for gay men and lesbian elders. On our webpage, you'll see that in our diversity and inclusion menu, at the bottom there, we do have something about LGBT outreach, and I think that's important for people to see. Just having those words and that acronym there sends a message of acceptance. This partnership with SAGE has been extremely successful, and so we're still doing an ongoing collaboration, and that has now extended to our national association, and it's a really good example of taking something from the local level and bringing it to the national level. So we do a lot of cross-training, and we have this national strategic partnership and affiliation. And SAGE has, I think, many affiliates around the country. The numbers of groups have grown. I believe it might actually now be 2 groups. We might be recruiting for another. So the group membership has been steady and consistent and has worked out really well. Okay. Something else that we have done here, and based on some of the training that we got from the National LGBT Resource Center, is that we changed our forms and our paperwork to reflect partner, to reflect transgender. So one of our options is, when you look at gender, it's male, female. We have male to female and female to male. And we have a formal non-discrimination policy as part of our work here. Something else is that in our newsletters and in our publications, we're writing about the LGBT elders. This is an example. It's called Advancing Care. It's a newsletter for staff who work in adult care facilities, and it's free of charge. You can subscribe for free, and you can get that when you at alznyc.org/LTC. And this is just one example. There are other good examples as well. And I'm going to end on just talking about the need for research. Although there is a growing body of research on LGBT aging, and the National Resource Center on LGBT Aging is a terrific resource, and they have lots of material that's very, very helpful. And there was one on caregiving, but there's very little actually on dementia-specific concerns. So at the International Conference on Alzheimer's Disease, in both the past 2 years, there were no specific research or papers that presented on LGBT and Alzheimer's disease issues. So in conclusion, what we've learned is that the key to recruitment and outreach was identifying the right community partner. And we needed to commit and to evidence that we were an LGBT affirming and friendly environment, and that constant presence and follow-through allows people to trust you and begin to see that you put your money where your mouth is. So staying engaged, which we've done over 20 years with SAGE, I think has been really great. And cultivating and changing the relationship and nurturing that relationship has been really successful. So I have here a list of resources for you if you're interested in looking at seeing more. The National Alzheimer's Association has a brochure on LGBT caregiver concerns, which is terrific and is available on our website. And there's some more resources for you. Family Caregiver Alliance actually has some interesting information about caregiving as well in the LGBT community. And there is my contact information. I think I just went about 1 minute over, so appreciate the opportunity to share this information today.
You were great, Jed. That was absolutely fine. Thank you so much for your presentation. I'm going to hold the questions that folks are putting into the chat feature until Ann Wolf is done with her presentation. As a reminder, webinar. And now I'll introduce Ann Wolf. Ann Wolf is currently serving as the supervisor for the Community Resources Division of the Lieutenant Governor's Office on Aging, the State Unit on Aging for South Carolina. Ms. Wolf served as the project director for multiple ADDGS and ADSSP grants during her tenure with the Office on Aging. She also served as the program manager for the Alzheimer's Resource Coordination Center, which provides grants to organizations for dementia-specific respite or education programs. And also co-authored Conquering the Specter of Alzheimer's Disease in South Carolina, a state plan to address Alzheimer's disease, and is the co-author of Take a Break, South Carolina, Sustaining South Carolina's Caregivers Through Respite. So without further ado, I'm going to send it over to Anne for her presentation.
Thank you, Sari. Good afternoon. I'm very excited to share with you our outreach initiative, which was part of an ADSSP grant project here in South Carolina. So, to prepare for successful outreach, we had to get ready. The first step was to choose our partners. We chose partners that were well known in the community. They already had a place of trust and acceptance. All were very high profile, well known in the Tri-County target area of Charleston, Dorchester, and Berkeley counties here in South Carolina. The Alzheimer's Association South Carolina chapter has an office located in the targeted Tri-County area, which was really instrumental. The Trident Area Agency on Aging, which is also an Aging and Disability Resource Center, made use of a mobile unit to provide outreach, education, assessment, and choices of options for services to people with Alzheimer's disease and related disorders and their family members. It operated in underserved rural areas of Charleston, Berkeley, and Dorchester counties. Assessments were provided by the ADSSP program coordinator, who was hired under the grant, in conjunction with the AAA's Family Caregiver Advocate. The Medical University of South Carolina Alzheimer's Research and Clinical Programs has ongoing clinical trials for ADRD and conducts screenings in the community. The primary mission of the MUSC ARCP is to study the effect of cardiovascular risk factors in the development of Alzheimer's disease among African Americans. This was a perfect synergy for our project because they were already targeting part of the population we were targeting in our grant. The University of South Carolina Arnold School of Public Health Office for the Study of Aging brought the component of Dementia Dialogue. Dementia Dialogue is a 5-session training program conducted through their Office for the Study of Aging. It's designed to educate individuals who care for persons who exhibit signs and symptoms associated with Alzheimer's disease or related disorder. So, you have your partners. Now it's time to set your goals and objectives. Our goal, we had one overarching goal for our grant, and that was to improve access to home and community-based services for individuals with Alzheimer's disease or related disorder by targeting underserved minority and rural populations. Our objective, and this first objective is the one I'm going to concentrate on today, was to implement strategies that build familiarity and trust among underserved minority populations through outreach and education among local churches and existing community networks. We also had 2 other objectives: to provide medical screening and to provide vouchers that allowed increased services for caregivers and persons with Alzheimer's disease. So we now have our partners, we have our goals and objectives. So it's time to get set. We needed to establish our problem statement using relevant statistics. For example, South Carolina ranks 5th in the nation in percentage of minority residents and 4th in the nation in percentage of African Americans. South Carolina is a rapidly aging state with a large African American elderly population concentrated primarily in rural areas, and factually the majority of South Carolina is considered rural. And finally, more facts. The targeted counties in our ADSSP grant have a higher than average minority population: Charleston County at 34.5%, Berkeley County at 26.6%, and Dorchester County at 25.1%. So we now have all of our ducks in a row, so to speak. We need to find the right person for the job. We hired a program coordinator who was housed in the AAA. He had an extensive background of experience with Alzheimer's programming. he was already very well known in the area. Likewise, we hired a case manager / outreach coordinator who was housed in the Alzheimer's Association office, and she was well known in the area. She had an extensive background in community efforts through area churches. Both of these staff members who were hired under the grant brought many years' experience in grassroots efforts. So now we're ready to do great outreach. Our first arm for outreach was to faith-based communities. We made many discoveries along this journey. The first was that reaching church leaders may mean some non-traditional hours for your employees. Small churches frequently did not have staffing during the weekdays. And likewise, it's difficult to reach pastors who don't have regular office hours. So to overcome this hurdle, our outreach coordinator contacted local ministerial alliances. This provided the opportunity to reach several ministers at one time, as well as reaching those who don't have office hours during the weekdays. So what we did was figured out that congregants make great volunteers. They are already known and trusted within their church community, and we chose to call them family consultants. That was a name that resonated for the people with whom we were working. We were able to recruit and train 42 volunteers during our grant period. Our training was accomplished through the Alzheimer's Association in conjunction with the Trident Area Agency on Aging. Our family consultants were surveyed after the training to ascertain the value of the training provided, if it was beneficial, if it was what they needed, and what they would need going forward. We also discovered during the course of our project that training and retention of volunteers required a considerable ongoing demand of time and resources. In order to sustain this area, we created what we considered a foundational structure so that contact with volunteers remained consistent through meetings, additional training. We had a family consultant newsletter specific to each church. And I use the term newsletter with quotation marks around it because it wasn't exactly a newsletter. It was more in the line of a one-page flyer. But what we did was take the opportunity to talk about our program, to talk about services available in the area, and to use it as a form of volunteer recognition. We would highlight a specific volunteer / family consultant who had done exemplary work or, was being recognized for some reason in that issue. So that's how we addressed our outreach to faith-based communities, which was very successful. I, just as an aside, spoke with our vice president for the Alzheimer's Association South Carolina chapter just the other day, and he wasn't aware that I had been signed up to do this, but he said to me, we are going to try to institute the family consultant program in other areas of the state, and they're going to rebrand it to, appeal to the specific regions. But I thought that was such a telling statement that this has really withstood the test of, is it sustainable after a grant ends? It was very exciting. So the next arm for our outreach was using existing community networks to build some support groups. First off, you need to know your community. Contacting local community leaders was very successful. We had mayors in 2 small towns who were excited about the project and offered staff assistance from their communities. We also identified sites that were appropriate and available for group meetings. And again, this is where, if you make those local contacts, many times people will say, the VFW hall is available on Wednesday evenings at no charge. Those are the kinds of areas where you can start embedding your program locally. And it's important to identify local people who are willing to spearhead the clubs. Next, you need to meet the gatekeepers. And what we learned is that the gatekeepers are not always who you would expect. We asked the question of local residents, who do you go to if you need something done? Frequently, it was not the highest profile person or the elected official. For example, in one community they said, oh, that's Miss Lizzie. She does everything. She takes care of everything we need. That's who we contact. So really, you need to know your local area and know to whom you're going to start putting out the feelers. We also had a family caregiver who had received a respite voucher through our program, who was actively assisting with the creation of a group because she saw the value of the program firsthand. And I am getting ready to add one that I think we all know, but it bears repeating. Retirees make great volunteers. We had retired teachers, we had retired nurses, folks who are willing to donate generously of their time and expertise. So, what were we doing with these existing community networks? Well, we were creating what we termed self-help clubs. Our target audience didn't like the name support group. I'm not sure why, but that didn't sit well with them. So they branded themselves self-help clubs, and we called it support groups with a twist. What we did was create an empowering social club, is how we referred to it. They had monthly meetings encompassing music, food, and a question and answer session. Frequently, we would ask an outside speaker to come in. For example, an elder law attorney would come and discuss concerns from participants. And we let them, choose what areas they wanted information on, what they needed assistance with, and we tried to make those linkages. We found that collaborative efforts were fabulous between the self-help clubs and community partners, including the area technical college, area churches, health clinics, and existing respite programs and support groups. In addition, we incorporated dementia dialogue training so that we were able to provide it to the caregivers participating in the self-help club. And after dementia dialogues training, we were able to offer a dementia dialogue train the trainer course. That created a local resource where we did not have to worry about, how are we going to sustain this? How are we going to find a trainer? These folks in the community were very engaged and very interested in making sure that their program was embedded within their communities. They could go on even after the grant project ended. So, the other area that was critical was to take care to cultivate leadership and cohesion within the group. It is generally the case that somehow a leader always seems to come to the fore, and that is fantastic. We were able to find those, we called them shepherds, who were able to steer these flocks and help folks to keep these projects up and running. We had some small towns that could not sustain their own self-help clubs, but they were interested enough that they combined with other small towns, and they are all located closely enough that, for example, folks would give each other rides. We're going to meet next month. No problem, I'll pick you up. It was truly a phenomenal community spirit. So as a final thought, while partnerships between nonprofits, academic, and faith institutions are uncommon, this approach thrives in our project. I think one of the sustaining lessons that I took from this project was that the only limit is what you self-impose. It became evident to me that resources and support came from areas that I wouldn't necessarily make the association. So even though it may seem like, okay, that's an odd one, a technical college, you never know who your partner wants to be. So I encourage you to reach out and think, to use the term outside the box. Finally, there's my contact information. I would love to hear from you if I can answer any questions or help you in any way. And I thank you.
Thank you so much, Anne, for your presentation. And thank you also to Jed again for both of you for volunteering your time and providing such excellent information for our participants today. So a number of questions have come in while you've all been talking, and I wanted to start with the questions that came in during Jed Levine's presentation, give Anne a few minutes to catch her breath. And the first one was just a basic question. They were wondering what a calendar listing is. And then another question that you can just answer right after was if the program used mediation services at all to help families work through conflict relating to elder care and finances.
Mm-hmm. Well, first of all, a calendar listing is actually a free way of getting an event marketed in a local newspaper. It's not an advertisement. Often they will have calendar listing of community events. And so often local television stations will do that, and local newspapers will do that. So that's what a calendar listing is. And around the issue of mediation, we have actually worked with mediators. We don't have them here, but we have referred families to organizations that provide mediation to help families resolve the issue of providing kind of what kind of care needs to be provided, where it's going to be provided, and to resolve issues of conflict in families. So yes, we have referred to mediation organizations that provide that service.
Great, thank you. Another question that came in during your presentation, Deb, was asking if there's any outreach resources for rural communities for the LGBT population.
Yeah, I believe that SAGE has some, and I think also if you look at the National LGBT Resource Center, they might have some as well. It's interesting, in New York City we don't have any rural areas, but I do believe that there are some. I'm not that familiar with it, but I can do a little research and get back to you.
Great, thank you. A few people actually commented on the long-term planning for LGBT partners. Do you have any other suggestions, or do you want to talk a little bit about the resource that was mentioned in the chat, the Lambda Legal?
Yeah, there are a couple of thoughts about that, and it certainly is a very important consideration, especially for partners that are not legally married and where same-sex marriage is not allowed in their state. So you want to make sure that you do have certain documents in place. And I would strongly encourage people to see an elder law attorney who is familiar with planning for same-sex couples. But you want to make sure that you have a documented healthcare proxy and other advanced, healthcare advanced directives in place. You want to make sure that you have the ability to step into the shoes of your partner and be able to manage their financial and business affairs as well. So you want to have a durable power of attorney to do that. And although these documents can be executed on your own, the healthcare proxy certainly, and I would encourage people to go to their state departments of health and find the healthcare proxy. It's important to make sure that they are properly executed, because if they're not, they are invalid. And you also want to make sure around the issues of inheritance, that there's a will, so that a spouse or a partner can be provided for if one of the partners deceases. So I think those documents are really important. A living will is important, and it's also important to make sure that you have these documents like a durable power of attorney available to you, that you don't keep them in a safe deposit box, because if you need it on a Saturday night, you're not going to be able to get it, but have it accessible to you. And make sure that your physician and your other healthcare providers know that you have the healthcare proxies as well. But the Lambda Legal, which is a wonderful advocacy organization, does have terrific publications and has information on their website about planning for care and making sure that the appropriate legal documentation is in place.
Great, thank you. The next few questions came in for Anne. Someone was asking about the Dementia Dialogues curriculum. Can you talk a little bit about if there was a cost associated with it, and also just give a brief overview about that curriculum?
I'd be happy to. It is free of charge, and I actually went through Dementia Dialogues training when I first started at this office back in 2007. It is primarily targeted for caregivers, but I can tell you that it is appropriate for anyone who works with individuals with Alzheimer's disease or related disorder. You can find more information if you go to the University of South Carolina website, Arnold School of Public Health, Office for the Study on Aging, and you will see where you can pull up information on the curriculum. There is a contact for the person who is spearheading that program. It is tremendous, and it has been presented to thousands of people all over the state.
Great, thank you. And someone asked if the training that you did is available to elder service employees. I'm not sure if they were asking if at the time of you were doing it, was it available to elder service employees, or if they're asking currently, but can answer either or both ways.
All of the above is accurate. It always has been available to whomever, and professionals who choose to go through Dementia Dialogue receive a dementia specialist certificate at the end of the training, and a lot of people do that to enhance their training that's already in place with their respective employers.
Great. Another question came in about the self-help group. How did you care for the individuals with dementia during those self-help clubs?
We are very fortunate. Our Alzheimer's Association offers free respite service to anyone who wants to participate in a support group in South Carolina. And as they were a partner in our grant project, they extended that through the grant. We also have multiple funding streams for respite vouchers. So we try to make sure that our caregivers are aware that there are funds and services available if they want to participate in these groups.
And can you talk a little bit about the relationship with the churches and if they provided ongoing space for you, and did those relationships maintain themselves afterwards?
Well, the faith-based community outreach was primarily for the volunteer base, the family consultants. If it happened to work out that a church was available for a self-help club, it truly was just a matter of finding what was available in these respective communities. Sometimes it was the town hall. It might have been a church in another community. It was just purely a matter of the resources and needs of each community.
Okay, and have you heard of or seen any kind of information about self-help clubs for people with dementia as opposed to the caregivers, or some other kind of support group with a twist, like you said?
Well, we have in South Carolina several support groups for early stage people with Alzheimer's, and a lot of those are funded. It's interesting because our Alzheimer's Resource Coordination Center, which Sari mentioned in my bio, we fund seed grants, and some of our grant recipients have respite programs that are geared to not only the caregivers, not respite programs, but the support groups. geared not only to caregivers but to those individuals in early stage, and they have actually tried to, some of them, create a network where the person with Alzheimer's is able to continue in a group even as the disease progresses.
Okay, great. And then we had one question come in about any of these types of services available in Mississippi that you know of.
I don't know about other states. In my opinion, a good place to start would be with your state unit on aging and your Alzheimer's Association chapter for your state. We have enjoyed a really healthy, very beneficial relationship with the Alzheimer's Association, and it ultimately serves the people we serve very well.
Great, thank you. And then, another question came in about the family consultants. Did they receive any training?
They did. We set up training. The Alzheimer's Association already had some structured training in place. So they, in conjunction with our area agency on aging, provided formal training for our family consultants.
Great. Let's see. Another question just came in. Can you say a bit more about the network for people with dementia that helps them stay in touch with a group as the disease progresses?
Well, there is no statewide network. I am referencing specific programs of which I'm aware in the state. We unfortunately don't have that kind of comprehensive network. Hopefully one day.
Let me just add that the association has a very active online presence, and part of that presence is a chat network for, it's called Alts Connected, and there is a very active activity for people with dementia as well as for their caregivers. And there is a separate, and I should have mentioned this earlier, there is a separate resource for LGBT caregivers as well.
That's great. Thank you so much. So right now, it looks like some other people are typing in some questions. We have a few minutes left. Are there any comments that either you, Jed, or Ann want to make that you weren't able to make during your presentations or that have come to you during this part of the webinar, during the questions and answers?
Well, there's one resource that we're learning about online here through the chat system is Project Visibility, which I understand is in Colorado, but is for LGBT elders, and I think and has a rural component as well. So that's something for everybody to take a look at. I'm not familiar with it. And I also just wanted to reiterate around the legal and financial planning for long-term care is especially, it's critical for everybody, but it's especially critical for same-sex partners because especially at a time when somebody wants their loved person there, their loved one there, and they can't, they're not allowed because they might not have the legal authority. It's important to have whatever documentation and authority you can get to be the person who is going to direct the care and be able to visit as well, because that often is a situation.
Great, thank you. And so a question came in about the, you were mentioning Alts Connected. Is there a separate link for the LGBT chat?
I believe there is. I think if you look at alz.org and go to Alts Connected, I'm trying to do it now on a tablet, under Community, Alts Connected, I believe that there is. So Caregivers Forum, and yep. So I believe there is, but again, I can follow up with you later, Sari, and you can share that information.
Sure, that's fine. And any other comments you want to offer? The information that's coming through on the chat right now is many, many thank yous to both of you. So I just want to echo what everyone's saying. But Ann, if you have any other comments before we sign off, we're happy to hear them.
I don't have anything top of mind, but as I said, my contact information is attached, and I am happy to help in any way I can. I appreciate the opportunity to present.
Okay, great. And just to everyone who's still here, if you have general questions or questions for either of the presenters, you can also send them to me and I can forward them on appropriately. I just entered my email address there in the closing notes. So without any other questions coming in, I just want to thank you one last time. Your time and efforts today are so wonderful to hear. Two very different programs for two populations that sometimes are hard to reach. So thank you again, and we look forward to having you all on another webinar very soon. Thanks so much, everyone.
Thank you.